Hi, good afternoon, everyone. I'm Alissa, a research assistant professor at the Department of Surgery here in the Chinese University of Hong Kong. So thank you to the organizing committee for the opportunity to present our work on patient-derived organoids and how they inform pharmacogenomic vulnerabilities in liver cancer. So just for a bit of context, liver cancer, primarily hepatocellular carcinoma, is the sixth most common and third leading cause of cancer-related deaths worldwide. Unfortunately, the majority will be diagnosed at advanced stages, whereby systemic therapy is their main course of action. So despite recent advances in treatment options, only a subset of patients usually benefit, as marked by only 5 to 30% of objective response rates. So unfortunately, there's no clear patient stratification for these treatments, and this problem is further compounded by the issue of intratumoral heterogeneity, as well as the fact that the top driver mutations in HCC remain undruggable. So these issues are partly due to the lack of representative in vitro models that can recapitulate ITH as well as the top driver mutations in HCC. So one way that we could address this is by using patient-derived tumor organoids, or PDTOs. So the recent consensus defines organoids as 3D structures derived from stem cells, progenitor, or differentiated cells from their tissue of origin. So it's very important that they're able to self-organize through cell-to-cell or cell-to-matrix interactions, which often involve the use of base membrane or matrigels. They must be able to recapitulate aspects of the native tissue architecture as well as function in vitro. Most importantly is they can also recapitulate intratumoral heterogeneity as well as mimic to some extent the patient treatment response, has been reported in other cancer types. So because of this, they have been adopted for drug development and testing, disease modeling, and precision medicine, among others. So among the technological barriers in the adoption of these patient-derived tumor organoids in precision oncology, particularly for liver cancer, is the low success rate. Compared to other cancer types, maybe it's about only 20%. So the high operational cost, so not only is it labor intensive, but also the cost of expense growing using growth factors and reagents is quite heavy. Lack of standardization, particularly for certain components in the medium as well as matrigel, and most importantly is the protracted timeline. So if you want to apply to the clinic, it often takes a long time to establish organoids for drug screening, which do not fit the existing clinical timeline. So to tackle these problems, we optimize the organoid establishment method primarily using growth factor reduced media, and further developed a drug screening protocol amenable to drug discovery and personalized therapy. So for this study, we attempted to culture 100 organoids from 100 patients who have undergone surgical resection at our hospital, at the Prince of Wales Hospital. So of which I think 77 we could confirm as quantified tumors based on the presence of known HCC driver mutations. So we suspect that the attrition rate sometimes could be due to tissues sampled from necrotic areas. So their initial viability usually presents as very low. So from this cohort, we were able to successfully establish 73 or 95% success rate for short-term culture, which we define as organoids growing for more than 8 weeks but less than 20 passages, and a further 23 or 30% successfully established for long-term culture, which we define as growing for more than 20 passages with stable biobanking. So interestingly, we noted that for the last few steps, from short-term to long-term success rate, they can be adversely affected by some fibroblast outgrowth and definitely the smaller starting material because they rely on the heavy seeding density. So this is a summary of the patient-derived tumor organoids that we've successfully established from a broad spectrum of clinical and genetic patient background. So we can see that nearly all of them could be established actually using growth-reduced media. So we then comprehensively characterized the panel of 10 tumor organoids that represent a broad range of the histological grades. So here we're showing it in the order of well to poorly differentiated HCC. So as you can see from the H&E, they are able to recapitulate the histological features from the primary tumors, and we also observe a varying range of HCC tumor and hepatocyte lineage markers as shown in the IF here. So interestingly, steatosis was also maintained in the histology for some of the cases from NAFLD patients. So we also performed full exome-seq and RNA-seq on the same panel of organoids, and we found that indeed they can retain the intratumoral heterogeneity. You can see here based on their variant allelic frequencies that there are some patients who have maybe one major clonal population, whereas others may have two or more. So this suggests that ITH is well maintained in our organoids. The organoids also retain the same chromosomal aberrations as well as transcriptome profile of the native tumor tissue. So more interestingly, the organoid doubling time, both in vitro and in vivo by orthotopic injection in immunocompromised NSG mice also reflect their histological grade, so whereby the well-differentiated tumors tend to grow much slower than compared to the moderate to poorly differentiated tumors, which are known to be more aggressive. So we then performed elastic net regression analysis of the somatic mutation landscape and integrated it with the drug response data from 100 FDA-approved and pipeline anti-cancer compounds. So this result revealed that we can get over 1,000 variant drug predictive pairs showing either sensitivity or resistance. This data can be used to stratify patients with certain mutations to existing therapies for HCC, as well as repurposing for FDA-approved drugs to previously undruggable mutations. So on the stratifying side, we found that the PDTOs with TP53 mutations, particularly the missense mutations, showed sensitivity to lenvatinib, which is one of the first-line systemic therapies for HCC. So not only did they show better response in vitro, but they also reflect this result in a small cohort of HCC patients who have received lenvatinib in our hospital. So this is also marked by improved overall survival in those patients with TP53 missense mutations receiving lenvatinib. So on the repurposing side, beta-catenin gain-of-function mutations are among the top driver events in HCC that remain undruggable. So here we report that ceritinib, it's an ALK targeting drug, showed response in beta-catenin mutated versus wild-type counterparts in an expanded cohort of 20 organoids. So this is the in vitro data. You can see that the IC50s are significantly lower on the mutant organoids, and this is also reflected in the live-dead imaging, as live-dead quantification and imaging at high content. We also observed the same trend when we performed the in vivo orthotopic injection, the PDTOs, where the mutant showed marked regression of tumor burden after certain treatment. So this is quite intriguing because there are no ALK fusions in HCC nor ALK expression, but a previous study in non-small cell lung cancer did report that there's a polypharmacological targeting outside of ALK, whereby one of them is RSK2 can also be activated by the beta-catenin mutant-mediated non-canonical Wnt signaling pathway. So, in the interest of time, we didn't show too much on the mechanism, but we're happy to open the floor later for further discussion. So, in terms of for personalized medicine, we provide genome-guided patient-derived organ testing to support individualized treatment decision in 2 cases as a proof of concept. So for the first case study, we have a 17-year-old male who was diagnosed with recurrent liver cancer. So he was heavily treated, and unfortunately he was refractory to basically everything. So he had transarterial chemoembolization, radiofrequency ablation, as well as undergone the first line systemic treatment and even immunotherapy. So this is what his organoid looks like in culture. When we performed whole genome sequencing on his organoid, we did see that there's 2 potentially actionable alterations, so namely the EGFR and MET copy number gain as reported in lung cancer. But of course, these 2 are not known to, based on clinical trials, these cases are not really known to work for HCC. So we then tested these drugs in the organoids, and we found that indeed erlotinib showed the most sensitive to the organoids. And indeed, when we gave this to his oncologist, he upon receiving erlotinib, the patient showed encouragingly complete response at 5 months. So you can see not only from the liver, but also in his peripancreatic metastatic site, as shown in his CT scans here. So before and after treatment. And the treatment seems to be quite robust, even 23 months in, based on the CT scan. And based on his serology, he continues to be quite well since the last follow-up, so maybe around 4 years since he started the treatment. So the results were very encouraging. So for the second case study, so it's also an HCC patient, 61-year-old male with advanced HCC, also refractory to first and second systemic treatment. At that time, he also presented with pulmonary mets. So we used this to establish the organoid from his biopsy. So this is what it looks like. When we performed the full exome sequencing of the tumor, it revealed potentially actionable targets such as TSC2 frameshift mutations, potentially benefiting from mTOR inhibitor everolimus. So this has been reported in other cancer types like head and neck or tuberous sclerosis, but again, we don't know whether it will work for HCC. So indeed, for this patient, he did receive everolimus as part of his treatment. He did show partial response. So unfortunately, we didn't have the scan because he received the treatment overseas, but he did follow up with us and kindly shared his pathology, and he continues to be well. So at least 2 years into his treatment. Sorry for the delay. So in summary, you can see that patient-derived organoids inform pharmacogenomic vulnerabilities in liver cancer. We were able to use minimal growth factor-derived tumor organoids to mimic the histology and genetic heterogeneity of HCC. We were able to define pharmacogenomic indicators for patient stratification as well as drug repurposing used. And we have two proof of concept case studies that demonstrate clear patient benefit, so suggesting that we're heading in the right direction. So, of course, building up on our findings, it would also be beneficial to further develop the organoid model system to model the complexity of the TNE, especially to test immune checkpoint inhibitors, which are actually more predominantly used now rather than just the TKI, such as the luspatercept. So, it would be much more useful in the clinic to be able to know whether these ICVs would also work and which patients could benefit from them as well. So, last but not the least, thank you to our dedicated team, multidisciplinary team, and collaborators, both local and overseas, the funding agencies, and most importantly, the patients and their families who have made all this work possible. So thank you very much for your attention, and I welcome your questions, or you can also feel free to email me if you have anything, any burning questions. So thank you very much.